دكتور محمد مطر، دكتور محمود أبو زيد from Egypt، دكتور حسام السردي، دكتور علي أبو رمان، دكتور شوكت.
ما أدري، شوف نجرب.
بس أهم شيء نشوفهم شغالين ولا لا.
كله شغال، أنا جربتهم مو مشكلة.
ها؟
يوم هاي الحالة
مش شغالة ولا شغالة؟
شغالة بس مش محمول اللوب.
اعملها لوب، اعملها لوب بدون لوب.
ناخذ دقيقتين نعمل.
بدك تبلش بالحالة تبعتك؟
لا انت لا ايمن انت مثل التسلسل اللي يريده.
طيب
زي ما انت تقدم.
اي حالة ايمن موجودة؟
موجودة بس تقدم برودكشن هذه على الكارديو ثوراسيك سوسايتي مالت العراق. كيفك انت؟
انا هي خلصت.
الله يعطيكم العافية. احنا عملنا يعني افليشن مع العراقي كارديك ثوراسيك سوسايتي، ووقعنا اتفاقية معهم، وهي شراكة راح تكون دائمة ان شاء الله. وشراكتنا احنا ان شاء الله اي مؤتمر راح يكون في بغداد او راح يكون في العراق، راح يكون مجموعة اطباء القلب التداخلي الاردني انفولف فيها. وانا بشكر الدكتور عدنان والفريق العراقي كاملة على التجاوب الكامل معنا. هو دعم متبادل، وبنحييكم جميعا واهلا وسهلا فيكم. دكتور عدنان تفضل.
بسم الله الرحمن الرحيم. صباح الخير. Thank you very much, Dr. Mahmoud, again for your invitation. Actually, we are in Iraqi Cardiothoracic Society, are highly ready to support any activity in Jordan, and this is the 5th year we are here to collaborate with Jordan Cardiothoracic Society and intervention group, and the leader of this group is Dr. محمود زريق وكل الأخوة الداعمين الأساتذة دكتور ياس، دكتور عاصم النماس، وكل الأساتذة الموجودين، دكتور هادي أبو هنطش. We are ready to support and to collaborate for the research with Jordan, as Dr. Mahmoud said in the beginning of the conference. Also, we have 5 centers from Iraq will share in the registry of the coronary ectasia. Firstly, I would like to introduce our brothers from the, we have Dr. Mahmoud Mutar. He is a well-known consultant, interventional cardiologist. He is in the north of Iraq, in Kurdistan region, the Hawk Cardiac Center. Dr. Shaukat Miro, also from the Hawk Cardiac Center. He is one of the leader of CTO group in Iraq. Dr. Mahmoud Abu Zaid from Egypt, well-known consultant interventional cardiologist in Nasser City from Aimen Hospital. The panelist, Dr. Hussam Al-Saradi from USA, and Dr. Ali Abu Rumane, a cardiothoracic surgeon. He's graduated, I think, from University of Salahuddin, Dr. Ali. Welcome, Dr. Ali, in this session of Iraqi Cardiothoracic Society. It's my honor to start this session with Dr. Aimen Hamdan. He is a consultant, interventional cardiologist from Jordan, to start the session and to talk about keynote lecture about the no reflow phenomena. The floor for you, Dr. Aimen.
Good morning, everybody, and thanks for the organizing committee for giving me this opportunity. This is my show-off slide. Our case is a 38-year-old female with no past medical history. She presented with chest pain, angina diagnosed with anterior STEMI and cardiogenic shock. She had fever 3 days prior. Workup was done, but she was taken immediately to the cath lab. see if this is gonna. Can you play the movie? Okay, as we could see from the first injection, can you keep it playing? Go to the next. We got a total LED. Next. Wiring, which was a little cumbersome. Next. Ballooning. Next. Then we put a stent. Next. Stent deployed. Next. We were celebrating, then this is what we get. So the artery looks open, but the flow is compromised. So no reflow phenomena. As we know, acute coronary syndrome is considered to be the most important cause of death throughout the world. And despite the technological improvements, the new drugs and increasing level of awareness of PCI, which provides normal blood flow in the responsible artery in patients with myocardial infarction, contributing significantly to the regression of symptoms and better prognosis, no reflow phenomena reduces all these positive effects of PCI. It's defined as insufficiency of myocardial perfusion despite the mechanically responsible lesion being opened. Let's talk a little bit about ischemic injury. We know no reflow starts with the initial severe ischemic insult. We call it lethal ischemia, and it's defined by a myocardial tissue blood flow below 40 ml per minute per 100 gram of tissue. And it does cause irreversible cardiomyocyte and endothelial damage. At the endothelial level, there is bleb formation and endothelial protrusions are observed and obstruct the microcirculation, endothelial cell necrosis, which lead to destruction of the tight and the adherent junctions and loss of vascular integrity, which in turn leads to extravascular accumulation of fluid and blood cells. Now there is another injury once we restore the flow. We call it the reperfusion injury. The ischemia-related injury is made worse by reperfusion injury, which is caused by the brutal restoration of normal blood supply. That's going back to 100 ml per minute per 100 gram of tissue, which will cause damage to the microvessels and accelerate myocardial swelling, tissue edema, endothelial disruption, and inflammation. And also the production of oxygen-free radicals, which is enhanced by the reperfusion within the first few minutes of the restoration of flow, which takes part in the reperfusion injury. This term, no reflow phenomena, was coined in 1967 by a guy named Guido Magno in a letter to the editor in Lancet in September 9, 1967. Where he describes the inability to reperfuse rabbit brain regions made ischemic by artery ligation despite opening the artery. Some would tell you that this phenomena was discovered as early as 1948. Now, the rate of no reflow can reach up to 50–60% depending on the assessing method, especially in patients with acute coronary syndrome. And this phenomena is associated with poor prognosis, such as in-hospital and long-term mortality and advanced heart failure. Let's talk a little bit about the coronary microcirculation, which refers to blood circulation in vessels below 200 micrometer in diameter that are not really visualized by coronary angiography. The microcirculation consists of arterioles, capillaries, and venules, and it's believed that those structures participate in the microvascular obstruction and coronary no reflow. The arterioles have relatively thick, smooth muscle. They act as resistant vessels and are responsible for keeping the constant precapillary pressure of around 45 millimeter mercury in the setting of the autoregulation. In the setting of ischemia and reperfusion injury, arterioles contribute to the MVO and CNR through the impaired vasomotor tone and the propensity to in situ thrombus formation. There are approximately 2,200 capillaries per square millimeter in adult human hearts. It has been estimated that the human heart has approximately 8 million capillaries. Those capillaries host 1/3 of the myocardial blood, around 45 cc, which moves at an average speed of 1 millimeter per second at resting state. The venules have a weak, smooth muscle and consequently manifest weak muscular vascular response. However, coronary venules, they participate in the ischemia and or reperfusion by serving as preferential site for leukocyte platelet adhesion via the expression of adhesion molecules and subsequent inflammation. And in the setting of ischemia, reperfusion injury, those capillaries undergo constriction, obstruction, and compression, which leads to the marked reduction in the number of open vessels and diminished delivery of oxygen and nutrients to the surrounding tissue. Those capillaries are the main site of clogged microcirculation, and microvascular obstruction occurs as a response. Again, microvascular is believed to be the obstruction is believed to be the underlying pathophysiological mechanism of coronary no reflow. They are relatively frequent phenomena that develop following reperfusion therapy in patients with STEMI. The frequency after primary PCI really depends on the sensitivity of the diagnostic testing that's been used. As we could see from this, there is regional endothelial swelling, there is the endothelial blips, there is neutrophil plugs, swollen myocyte which comprise the vessels, there is the Rollet formation, and cell lysis and sometimes cell death. Let's talk a little bit about the TIMI, thrombolysis and myocardial infarction, and the grading system that we use. We say grade 0, complete obstruction of the infarct-related artery. Grade 1 is some penetration of contrast material beyond the point of obstruction, but without distal perfusion. Grade 2 is the perfusion of the entire vessel, but it's lower than the normal one. And grade 3 is considered the full perfusion of the infarct vessel with normal flow. Some even go and say grade 4, where you have the myocardial blush. How do we assess? Several methods we can use: angiograms, ECG, AKG, if the ST resolution is less than 50% from the baseline, coronary flow reserve or coronary MRI, myocardial contrast echo, and PET scanning. The angiogram is the one that's really we use a lot. It's readily available and most convenient to diagnose coronary no reflow, but it's highly conservative due to the suboptimal, too early timing of examination. Magnetic resonance is considered, it's a very sensitive method to diagnose microvascular obstruction, and it provides information on the presence, localization, and extent of the obstruction. They detect also intramyocardial hemorrhage and accurately estimate the infarct size in clinical setting. As we could see, the black area is the area that's not being perfused here. And if we look here, if you do any coronary Doppler, you lose your pulsatile flow. So microvascular obstruction and coronary no reflow markedly negate the benefits of reperfusion and contribute to the poor clinical outcome, including the adverse remodeling of left ventricle, worsening or new congestive heart failure, and increased risk of mortality. And you can see no reflow, the higher the degree, the worse was the outcome. Here again, increase in in-hospital mortality, reinfarction, and heart failure and cardiogenic shock. SST2 is an independent predictor in both short and long-term follow-up. Furthermore, as stated in the guidelines, the SST2 can be used in the diagnosis and follow-up of heart failure in addition to the PNP. SST2 is called the soluble suppression of tumorigenicity. It's a member of interleukin-1. Look at it as a bad guy. It's thought to play a role in cardiac remodeling and inflammatory process. The levels are considered to increase in cardiovascular stress and cardiac fibrosis that ultimately create substrate for fatal arrhythmias. And on a cellular level, this molecule binds to the good interleukin-33 to reduce its bioavailability. It's believed that interleukin-33 has a reducing effect on myocardial fibrosis, hypertrophy, apoptosis. There are studies suggesting that this ST2 is a predictor of mortality in patients with ACS. What are the risk factors for no reflow? From regression analysis indicate that patients who were diabetics, patients who were hypotensive, patients with multi-vessel disease, patients with high plaque burden, and patients who started with grade 0 TIMI flow, these were independent predictors of no reflow phenomena. Also the clot burden, the time delay between the onset of chest pain and intervention, the age of the patients, and high balloon inflation pressures were also common risk factors. As we could see from here, the longer you reperfuse, the higher the incidence of no reflow. How do we manage? Patients who were on beta blockers did better. Why? Because beta blockers apparently has an anti-inflammatory action and inhibit neutrophil and platelet aggregation. The use of calcium blockers as prophylaxis in roto cases does help, and there is a lot of emphasis on the use of epinephrine. We'll talk more about it. Some of the studies have shown that ticagrelol was superior to clopidogrel. Maybe that will explain why and I know we'll have a talk about ticagrelol, why it's more beneficial, or the mortality or the MACE was lower. That could be explained through the action that there were less cases of no reflow compared to clopidogrel. Cangrelol also is effective. Loading your patients with high dose of atorvastatins or statins does have an effect, and also ischemic conditioning is the most powerful endogenous mechanism to reduce the extent of myocardial infarction. Now, what medications do we use? There is pharmacological and non-pharmacological approach, where a lot of us, every institution has its own preferred medication. Adenosine can be used, and it might cause hypotension, chest pain, bradycardia, and dyspnea. Sodium nitroprusside, they're all intracoronary between 60 and 100 microgram. Could use verapamil, diltiazem, nicardipine. Also, the use of eptifibratides, tyrofibans, apiximab. Epinephrine is also used. There's a lot of emphasis. Intracoronary dose between 80 and 100 microgram boluses. You have to be careful for arrhythmias, sometimes malignant arrhythmias. Nicorandil can be used. Streptokinase, telantictase, TPA, apiximab. This is a trial, the AMISTAD-2 trial. We're comparing a placebo versus different doses of adenocard. Adenosine at 70 did show a reduction in the size of the infarct post-STEMI. There is also, sometimes you will read about these approaches. There is ischemic preconditioning, considered one of the most endogenous mechanisms to reduce the extent of MI. Prolonged balloon inflation helps. Thrombus aspiration can help. Filters had no documented effect on coronary no reflow. There is also the use of coronary sinus balloon occlusion. We spoke about venules being pooling of blood, so you might reduce that pooling. Hypothermic blankets, the chill MI and the cool AMI has not really showed much benefit. Some will use supersaturated oxygen and hyperoxygenated blood infusion. There's a lot of talk about the use of stem cell and the cellular approach via the pericyte use that does affect the vasomodulation. And always keep in mind the use of mechanical support if needed, if the patient is hemodynamically unstable. This is one of a hospital approach to no reflow. When they see it, they look if the patient has hypotension, yes, and is he bradycardic, then you might go for epinephrine. and 2B3As. If the patient is hypotensive, but he's not bradycardic, you could use adenocard and 2B3As. If the patient has no hypertension, and he's not bradycardic, then you could use adenocard, sodium nitroprusside, verapamil. But if he's not hypotensive, but he's bradycardic, again, you could use sodium nitroprusside and 2B3A. I mean, I used to use a lot of sodium nitroprusside. I know it does cause hypotension, but it's transient hypotension, and we had a lot of success. Everybody is probably used to a certain or familiar with certain medication. So when to stop? We stop once we restore flow, or if the patient's chest pain is...
Aimen, time
is up.
Okay. If the patient chest pain is free and he's hemodynamically stable, points to remember, always rule out dissection, thrombus, and air embolism. No reflow is really a diagnosis of exclusion. There's a higher incidence in STEMI and venous graft patients. Medication should be given via microcatheter. Avoid high pressure ballooning. Avoid multiple inflations. If large thrombus burden, avoid post-stent dilatation. Consider mechanical support if necessary. Consider relook after 48 hours. Cabbage per se can cause no reflow. Refractory cases, consider epinephrine. Can you run this? We gave the patient epinephrine. And we had TMI 2.5 flow. Next. Again, this is 2 studies showing the benefit of epinephrine. In case of resistant cases, epinephrine could be a good choice to use. Difficult delivery, we'll get there. We'll postpone questions later. Thank you so much.
Thank you very much, Dr. Aimen. Can you stay here to the floor because we want to finish everything, please? We want to take 3 questions from the audience and from the panelists. Dr. Mahmoud Abu Zaid, تفضل.
Very elegant lecture, Dr. Aimen. You covered all the criteria of the NoReflow. I would like to emphasize about some points you already addressed. The NoReflow is more dangerous than the no flow from the first place. As no flow from the first place, no high hydrostatic pressure in the coronary, so simple diffusion perfusion is going through the vasa vasorum or the blood itself from inside the heart. But during NoReflow, high hydrostatic pressure decrease the perfusion pressure through venules and capillaries and induce arrhythmia and more jeopardized myocardium. So the first comment is to anticipate NoReflow and go for the medication you mentioned before. In case of hypotension, we use epinephrine, and in case of high blood pressure, we use nitroprusside or nitrate. The second, I won't address, you also mentioned, but I want to address to be clear for everybody, the drugs specific for NoReflow should be injected intracoronary distal circulation through a microcatheter or through a perfusion catheter to induce the maximum effect we need. Thanks for your elegant presentation.
Thank you very much, Dr. Mahmoud. Just Dr. Aimen, any predictor rather than this classification for the NoReflow, because I go through some literature that they classify the NoReflow. We are talking about NoReflow in acute coronary syndrome in most of the cases. Can we categorize and put up predictors for those with CTO, NoReflow in CTO, NoReflow in acute coronary syndrome, and NoReflow in a complex PCI in chronic stable angina or chronic coronary syndrome?
I mean, the incidence is really high.
Also, there is no clear cut about these predictors.
Exactly. I mean, but you see it the most in STEMI cases. I mean, going through the literature, I was also surprised that you could get NoReflow post-cabbage. So those patients that you say, we did a great job, we revascularized all the vessels, but the LV looks like a stunt, that might be another. And like the doctor mentioned, you know, when you establish flow, it's like the myocardium is being slapped by the ischemic hypoperfusion injury, and now by the hyperperfusion, so it's like a double whammy, but you could see it in cases, but the highest is in STEMI.
Dr. Asim.
Incidence of knee reflow varies from 5 to 15%. Being highest in ACS wherever there is a thrombus, but it's even higher if you in vein graft intervention, where you need to prepare your patient with pre-medications. It may occur spontaneous, it may occur post-cabbage, same principle. And once you establish the flow to occluded LED by a lima, the same, you get no reflow. The most interesting part for me is ischemic preconditioning, which is, as Dr. Aimen mentioned, one of the ways to minimize no reflow and minimize reperfusion injury is repeated inflation and deflation of the balloon. Prolonged inflation, while you're in the same artery in the LED, for example, you do multiple repeated inflations, prolonged inflation and deflations, and inducing ischemia and resolving the ischemia. The other way is not mentioned in this lecture, which I didn't see it, but probably indirect, is remote ischemia, inducing ischemia apart from the coronaries. You mentioned called, I don't know what you call blanket.
Oh, the hypothermic blanket.
Inducing limb ischemia by multiple tourniquet is the same principle and been mentioned in treatment of reperfusion injury and no reflow. Thank you.
I mean, I agree. You were with us in the States. We had our share. I mean, one of the biggest things, we used to use a lot of NG-jet, and I remember the disasters we caused trying to NG-jet a clot from an SVG, and you break all these micro emboli, and things do go sour. So it does happen, and I think the most important thing is like to keep your posture and think straight and try to do the right thing for your patients. And remember, if nothing works, if the patient is hemodynamically unstable, you can always go to the mechanical support.
Last two short questions from Dr.
Thank you for your productive lecture. I am Dr. Hussein Al-Dawoubi, Head of Cardiac Surgery in Prince Hamza Hospital. I want to discuss this issue from the point of cardiac surgery, because when we are going to started cardioplegia to arrest the heart, we are facing this problem for no reflow to the capillaries, and the heart is not stopped at the proper time. So most of the time we are going to put retrograde cardioplegia and to go to the venous circulation and going backward to the capillaries and start to stop the heart. And we're using to cooling the patient and the topical cooling of the heart. Thank you.
Thank you.
Question?
تفضل دكتور.
Thanks, Aimen. Nice lecture. A little trick I use over the years is whenever I see unstable lesion in the term of how it looks, if it is ugly, I would never put a balloon before stenting. So I would do the stent and then maximize the way it looks after that. And that helped me a lot with avoiding no reflow.
That's a great point. They tell you if you see a lot of clot burden, and you put your stent, just don't go crazy and start, post-dilate. Just skip that. All it's going to do is going to break more of these clots and debris and shower it down the artery.
Thank you very much, Dr. Aimen, for nice presentation. So I will ask Dr. Mahmoud Abu Zaid. Last question, please. Yes.
Can I have a question? We all deal with the no flow the classical way. We give the medication most of the time, the problem solved. But every now and then we face with those studies about local thrombolysis in those who are very refractory, very critically ill. You did everything and you cannot solve the problem. Any position from anybody use it? Any position from the panelist or the speaker? Thank you very much.
Throwing everything in the sink. You try these drugs, and if it doesn't work, you could try, like you said, 2B3As. If I mean, the last thing you want to leave is like a slow flow in an LED. You really have not serviced that patient. So at that point, I would personally probably reserve to a mechanical support just to get him through the. And for the surgery, I mean, we know IV adenosine works. So I know you're not inside the coronaries, so you could use IV adenosine in that case, and that hopefully will help you.
Thank you very much, Dr. Aimen. Thank you.
Before before we're going to the next speaker, I'm add some interesting and new points regarding the prevention of non-reflow. Sorry. Some interesting point regarding the treatment of prevention, not treatment, because actually there is very interesting statement from Antonio Colombo. Once when there is non-reflow, mean the house is fired, the game is over. So as we know, the prevention discussed very nicely by my colleague, okay, but I'm going to talk about some procedural points which written recently by the clinical trials. First of all, you can give adenosine prior to the stent deployment, might be significantly decrease the risk of non-reflow. And secondly, if you are follow the vampire trial, which is a Japanese trial, which is very interesting for any patient with STEMI, you can go by the IVAS catheter and look for the lipid core. If there is a significant lipid core, you can use distal protection device and deploy your stent, which decrease the risk of non-reflow significantly.
Thank you, Dr. Mohammed.
No-reflow is a big issue, and the perfect is not to have it at all. Prevention, as our doctor said. I'm pleased to be with you, and I'm pleased to introduce our professor, Dr. Mohammed Matar, to speak about primary PCI mishap, challenges and solutions. Let us hear to him.
So good morning, Mr. Chairman, my lovely panelists, and my lovely colleagues. I will start my presentation under title of the STEMI, or acute coronary syndrome mishap challenges and the solution. So my case was 8 years old male octogenarian patients with a cardiac risk factor, with hypertension and dyslipidemia, and there was a history of chest pain for the last 10 hours. Presentation was extensive anterior STEMI with ST segment elevation and lead 1 AVL, V5, V1 up to the V6. Hemodynamically was unstable, with the blood pressure was very borderline, 80/50, and there is bilateral basal crackles. So the investigation-wise, the 2D echocardiography showed the moderate severe LV systolic dysfunction with estimated EF was 34%, anteroapical septal hypokinesia, and there is significant elevation of the serum troponin. Sorry?
Slides.
So it's clear now? So the lab showed a significant elevation of the serum troponin. At the ER, he was loaded with 300 milligram clopidogrel, referred for the urgent angio and the possible primary PCI. So this is caudal view. Show there is a thrombotic proximal Alhaideri lesion. There is a discrete lesion in the OM and the circ bad distally. This is a cranial view, the same, and this is the right coronary artery. Show there is a critical lesion in the mid segment. So the plan of the treatment to fix the calibrate lesion based on the clinical trial or guideline, just fixing the calibrate vessel and leave the others, depend before hospital discharge or later. So we start fixing the calibrate, which the lady by the wiring stent 3.5 by 38 was implanted with a satisfactory final result. His hemodynamic status become more stable with the normal auto saturation, blood pressure 100/70, kept in the ICU for the close monitoring. On the next day, he started to suffer from the very suggestive chest pain without no fresh ECG changes. The decision was made to revascularize the other vessel, circumflex right coronary artery before hospital discharge based on the guideline, which is class 2A recommendation. So we are going to the circumflex wiring both circ and OM and the provisional way pre-dilatation aggressively by the NC balloon using 2.75 up to the 20 bars, then stent deployed, and the result was satisfactory in the OM. The right coronary artery wiring stent deployed 3.5 by 22 with high pressure inflation, and the result was very satisfactory in the right coronary artery. So the patient was discharged 2 days later with a complete recovery, and 7 days later, the patient was brought to the ER after sudden collapse while in a shower. So on the examination, the patient was conscious oriented and complained from the dizziness and chest pain. The blood pressure was 80/40, pulse rate was 45, beat per minute was irregularly irregular. Chest and heart examination were normal, and the ECG showed ST segment elevation in the lead 2, 3, and AVF. The treatment was start with atropine 0.5 and noradrenaline drip. So urgent coronary angiography started. The patient was loaded by 180 milligram TICA based on the possibly there is some drug resistant. So the angio showed this total occlusion in the both circumflex and the LID, total stent thrombosis. So what we are going to do, wire after upfront intracoronary glycoprotein 2b3 inhibitors was given without any success, wiring the circumflex multiple balloon predilatation aggressively using 3O balloon and see, and the result was we achieved TIM2 flow in the OM and the CERC gone. Thereafter, we are going to wiring the LID and multiple balloon inflation using 4 by 12 NC balloon high pressure. And this is, we achieved TIM3 flow in the LID. Thereafter, I'm going to check the right coronary artery just to be sure there is nothing happened with the right, and this is the right coronary artery. There is total stent thrombosis in the right, so there is simultaneous triple vessel stent thrombosis subacutely. So wiring the right coronary artery, multiple balloon inflation, we are achieving TIM3 flow in the right coronary artery. Thereafter, he was kept on the glycoprotein 2b3 inhibitors for 24 hours, and genetic testing for the clopidogrel resistant revealed heterozygous gene mutation. In the follow-up, the patient was doing well until 5 days where he started to suffer from the central chest pain, abdominal pain, not responding to the analgesia. The lab tests show high white PC, high CRP, and there is normal chest X-ray, the unremarkable abdominal ultrasound, the CT serum amylase and lipase significantly was elevated, and the CT abdomen without contrast confirmed the diagnosis of the acute mesenteric ischemia with a possible thrombus involving the superior mesenteric artery. So we are going to bring the patient back to the theater and guiding the superior mesenteric artery, and there is a huge clot in the superior mesenteric artery. Again, another dose of intracoronary TPA was given in dose 10 milligram. An aggressive thrombosection was performed. Finally, we achieved a good resolution of the thrombus. Discharged 7 days later with a good hemodynamic status. Thereafter, I bring the patient back 6 months later just to look what's going on in the coronaries. He's doing fine, he's doing stable, LV function compensated with ejection fraction 35-40% on full anti-failure measure. This is the right coronary artery, and this is the LID. It's quietly patent and nothing wrong with the both vessel and even the CERC. So my home message is simultaneous stent thrombosis of second generation DAS in multiple coronary vessel is extremely rare, but still possible complication of the BCI that could lead to the catastrophic outcome. We should keep in mind multiple stent thrombosis and consider checking a platelet function and genetic testing in high-risk patients. New generation antiplatelet were also suggested as first line to avoid clopidogrel resistant according to the guideline. According to the randomized clinical trial, the most common predictors of the subacute simultaneous stent thrombosis was premature discontinuation of the DAPT, secondly, clopidogrel resistant, and thirdly, stent under expansion and malapposition. And thank you very much.
Thank you, Dr. Mohammed. Very nice presentation and demonstration of cases. For the sake of time, we ask to delay the discussion at the end of the session.
Okay.
Thank you very much.
Dr. Mohammed, the questions will be at the end together. Okay.
Sorry.
Okay. Okay. Welcome.
Okay. Thank you, Dr. Mohammed. Dr. Adnan, the most famous guy in Iraq. So please take the chair, and he's going to present a topic about can we win the PCI in primary PCI interventions.
Thank you very much, Dr. Shaukat. Actually, not most of the time we win the game in the acute coronary syndrome because of already we face a lot of things, expected and unexpected. So, this patient is 68 years old. He is a known case of previous ischemic heart disease and previous stenting for the left main to LID and left circumflex, presented with acute coronary syndrome and non-ST elevation myocardial infarction. And this is ECG with ongoing chest pain, and you can see the echocardiography. So, baseline angiography, you can see a patent left main stem LID stent, and that was the left circumflex with ostial narrowing, significant ostial narrowing, and as we know that the ostial left circ is a malignant disease. This is one of the things to remember. The RCA is accepted, and the plan was to do the stenting of this patient, and the procedure go through the tap technique, everything soft till something happen. This is the put also, and the result after that, the patient developing severe central chest pain with hypotension. Anybody can see something happen here? Left main section, Dr. Wael. Dr. Wael Qashqeri, you can see what is the problem? So the patient develops severe central chest pain, so the wire going outside, you think?
There is cusp dissection going to the ascending aorta.
There is cusp dissection, Dr. Shaukat?
Yes, there is a staining at the...
In the ostial and cusp dissection, yes. What happened here? Is it clear now?
Ascending aorta.
So this is a massive and horrible complications that we might face in the cath lab, so we should be ready for such a disaster. Actually, the patient suddenly developed also after hypotension with positive inotrope and everything. The patient has a VF with multiple DC shock. So what could you do first if you have such an unexpected left main coronary artery type F dissection? These are the choices. Impella, which is not available, try to rewiring, refer to the tertiary heart center. Is it the time for that? And just I say that we should have a close relation, because we cannot go without a cardiac surgeon team or go to the symptomatic treatment. Immediately, femoral, unfortunately, the wires and the guide catheter after resuscitation has been lost in this patient, but fortunately, we go through the femoral approach. That was in the radial approach, so we shifted directly to the femoral axis, and the rewiring with just to start to ask about any stent available to close this re-entry point, which was the graft. We should occlude the entrance of the dissection, and we are using the graft stent 4.15, up to 15 atmosphere, and that's the patient results. You can see, and after CT aortography, after 10 days, you can see everything is okay, and the patient was free from the chest pain, and everything has been settled. And fortunately, the patient survived these storms. So the iatrogenic coronary dissection is one of the major complications. Can we face it during the coronary intervention? And most of these procedures is due to the guide, wire, balloon, aggressive manipulation, and so on. So the summary in this patient, this patient with a STEMI, PCI, previous PCI of the LID and left circ, and there is a coronary artery type F, left main dissection, developed cardiogenic shock, deep engagement of the guide catheter in a false lumen, and aspiration of the 10 ml of the blood to reduce the false lumen, and no more injection was done. The main home message is that vigorous manipulation of the guide catheter and guide wire can lead to iatrogenic coronary dissection. Our case show how to be the vigorous balloon inflation also can lead to the dissection. Management strategy must be focused on restoring the coronary flow as quickly as possible. As the result of that, many registry there are many registry to prefer to use a graft stent versus a drug-eluting stent, but some there is no clear data about that. But if you can go to which is it available to use, second case please, to be ready and use to solve the problem, because most of those patients are in cardiogenic shock. And thank you very much.
Thank you, Dr. Adnan. Dr. Adnan, now I realize there are luckier people than me. Thank you very much.
So the last speaker, we are going to ask Dr. Ahmed Alhaideri to talk about lately realized what the problem was.
Just
the stage is yours, yes?
Discussion?
We will do discussion at the
but
end.
how many fellow attending this session? Interventional fellow, raise your hand.
No one here.
That's an amazing cases, and you know, the dissection, people, they think it's, even diagnostic card, they think it is straightforward without price. It's a good case to learn that everyone need to be really very careful handling catheter around that, the life artery, I call it the left main. It's very good, safe, and amazing work, Dr. Adnan.
Okay, thank you for this opportunity for introduce this case. This is a 47-year-old man present to the our CCU with severe chest pain for 4-hour duration. He has history of hypertension and a smoker. Chest pain is progressive, increment in severity from the early morning, associated with the sweating and feeling unwell. His examination was normal, just the blood pressure little bit elevated. Examination is unremarkable. ECG, it was normal or no significant abnormality, and lab tests are normal, just the troponin, high sensitive troponin elevated. Re-evaluate the troponin after 4 hours is more elevated. So the diagnosis was acute coronary syndrome with non-ST elevation MI. Treatment was
beta blocker, aspirin, ticagrelor in loading dose, statin, and anticoagulant. Coronary angiogram done after 20 hours of a presentation and show normal left main stem. LAD has no significant lesion. LCX showed distal clot occluding lesion, and RCA show mid-infiltration by atherosclerotic change. This is the angiogram for the patient. So PCI for the left circumflex initiated with easily passing wire, and as the flow, distal flow, become clear, we decide to do direct stent with the drug-eluting stent 2.25. When reaching the target, inflation was done for the stent, but the result was unsatisfactory. And we don't know why. Reintroduction of the stent balloon for further inflation, the lesion, as the lesion persists narrow, show resistant, and the reinflation trial fail as the balloon not reaching the target and enforce pushing of the balloon against that resistance, causing disengagement of the wire and disengagement of the guide catheter and withdrawal of them to the aorta. Another trial for engaging the circulation to the left main stem and cannulation for the main stem and pass wire distally with little bit difficulty by multiple manipulation was made. Then stent balloon not pass on the wire. So another balloon, a new balloon, take the mission. When inflation the balloon, aiming to prepare the and dilate the lesion, I saw there is unusual, unequal expansion of the balloon with upper proximal radio opacity here. At that time, we realized that there is a stent loss occur in the early trial, and now we are dealing with stent dislodgement distally in the left circumflex. So what is the option? We are now managing a complication of stent dislodgement. The wire is almost beside the stent. The balloon, the newly balloon, mostly crushing the stent in situ. And the site of the problem, as you know, is distally. You know, dislodgement of the stent is uncommon complication, can occur, and its management depend on the complete loss of the stent or partially loss of the stent, and if the wire is inside your stent or outside, and the location of the stent dislodgement play a big role in the management, and either retrieval or stent crush are the management. As these criteria, the balloon, the wire outside already, and the stent crushed by the balloon, we decide to crush the stent by another stent, crushing the dislodged stent by a new stent at that site is probably safer than retrieval of the stent, which is a complex time consuming, also material consuming. 2 stents are used to cover the foreign body completely due to difference in the proximal and distal segment, and this is the final angiographic result. The flow returned to the distal segment of the stent. Thank you.
Thank you very much, Doctor. So if there is any question from the audience for the speaker, yes, you have questions?
For your presentation, Dr. Mohammed, for your presentation, Dr. Mohammed, it was, do you recommend after these problems or corticosteroid resistance or whatever the cause, do you recommend ticagrelor for every patient, or you use it upon the anatomy of the patient?
Okay, thank you very much. By the way, according to the best of my knowledge, such case or my case, it's previously not described in the literatures or the reports. So I talked with my colleague just to report this case, because the only case that caused simultaneous subacute second generation triple vessel stenting. Regarding the clopidogrel, according to the guideline, the TICA and prasugrel is a class 1A recommendation, and the clopidogrel is used when there is not, when the TICA or prasugrel, it's not available. In my patient specifically, he's 8 years, he's octogenarian. He got history of the intracerebral bleeding 1 year back, and he was already loaded from other hospital and referred to my hospital to be proceed for primary BCI. So it's difficult to be loaded 8 years old by the clopidogrel and TICA. My opinion, my advice for all my colleagues, TICA and prasugrel definitely is more superior, as there's contraindication to giving clopidogrel because there is a risk of the clopidogrel resistant. Yes. Okay, in my case, so, if we are talking about my case, there is a lot of the risk factors for the simultaneous stent thrombosis. All of you know that could be patient-related, could be procedural-related, but what's happened in my case, from my perspective, my explanation in my case, possibly either or. First of all, could be systemic inflammation, prothrombotic melia, and acute coronary syndrome make the patient more susceptible for thrombosis elsewhere, cerebral, renal, or superior mesenteric artery. First, secondly, could be stent thrombosis, and the one stent thrombosis involving one vessel provoke the thrombosis in other vessel because of the severe hypotension that might be cause low flow and might be lead to thrombus in other stent and other vessel. This is my explanation. I don't think this case relate to the clopidogrel resistant because it's heterozygous. I don't think it's related to the procedural mechanism or patient related.
Regarding Dr. Adnan, it was a very nice cases to demonstrate. For the left main case, I would like to ask, it's not uncommon to lose a wire during CPR or patient agitation. What is the wire you prefer to rewire, and which curve you will do to avoid the dissection segment or going through strut?
Thank you very much, Dr. Mahmoud, for this thing. Actually, most of the dissection of the left brainstem is iatrogenic or guide induced. So sometimes when you are using a balloon and inflation, and you inflate the balloon, and when you pull the balloon, the guide go and do a dissection. This is number one. The second thing in iatrogenic stem dissection is that sometimes we are using over ballooning, and sometimes in PUT we are using an over pressure, especially when using NC balloon. So these are the main thing. Actually, we are losing the main important point or thing in surviving or saving the patient life in left main stem dissection is that if you will be so lucky if your wire is still in the LID or in the left circ. But when the patient develops shock or arrest, sometimes everything will be lost, and you should try. In our case, it was a radial access, and then we changed to the femoral, and the patient in arrest. So this is the main issue. Actually, I know no specific wire at that time of the crisis. You can use any wire available. Mostly we are in our center, in my center, we are using the pilot wire, pilot 50, pilot 100, and sometimes we are using soft. This is for the second. But in the primary procedure also, most of the wire are soft wires, BMW, all the wires are available. But at the time of the crisis, no, you can use everything available. Yes,
yes. What is more fruitful? Just hold that damn CPR for 90 seconds, throw in your stent and don't lose nothing, or just go through the CPR from ischemic point of view, from management point of view. Don't you think like I would just hold that CPR for 90 seconds, throw in the stent in the left main and game over, instead of CPR, get another access? You know, you were wasting more time probably just going through the CPR. What do you think?
Yes, I think this is not most of the time happen, because if the patient, you lost the guide, you lost the wire, and the patient in shock, and you don't have an impeller, and the surgical team is not activated, you don't have a hybrid cath lab. I think this is the main obstacles, and most of the cases we lost the patient, but sometimes we will be so lucky and save the patient like this.
I want to add some technical and educated points in case of the aorto-osteal dissection. By the way, when there is an aorto-osteal dissection, especially in the left main stem, the priority for the wiring, if there is no wire, not the priority for the mechanical circulatory support, because the mechanical circuit definitely will need time, so the patient will go in life-threatening or devastating cardiac arrhythmia. So the wiring is very important. In case of the aorto-osteal dissection, when there is dissection, the important point should be kept in your mind. Stop injection, non-selective engagement until the vessel is wired. The best wire to be negotiate the dissection with cyan blue wire, because it's not traumatic wire. Try to avoid as much as you can hydrophilic wire, because hydrophilic wire will be propagate more and more intramural hematoma and more dissection. Once you are wiring the vessel, then looks for the wire behavior. Taking any side branch, pass easily, any significant ectopy, no buckling of the wire, mean you are in true track. If you are in doubt, you pass IVAS catheter and look for your wire behavior if you are in true or in false tract. Once you are in true tract, very important, now go for the stenting. The stenting strategy is totally different from the non-dissected vessel, because you need a very long stent, at least 5 millimeter, distal and proximal, to avoid any retrograde or antegrade intramural hematoma propagation. Secondly, you can go for multi-stent strategy, stent distal, stent proximal, and stent in between. This is very safe procedure. Cutting balloon might be useful to be fencerate and decrease the size of the intramural hematoma. My question to Dr. Adnan, I don't know why the operator using the cover stent for the aortic osteal dissection left main. What's the indication for the cover stent as far as there is no any perforation? Once you are deployed cover stent in the aortic in the osteal left main stem, you know there is a high risk of stent thrombosis.
Okay, thank you, Dr. Mohammed. There are many registries, I will show you, that they prefer to using the cover stent in such scenarios. The main issue in such case, because you want to seal the entry point, so you don't know the entry point. If you don't know that this is the entry point, if you use a drug-eluting stent, the entry point or the section point will not be closed. So the covered stent is to close to be sure that to close the entry point. So this is number one. And at the time of this crisis, give me the cover stent and go ahead, just to save the life of the patient. Thank you very much.
Okay. I think yes. The last question, because we don't, it's okay.
The simple way to detect the problem, Dr. Alhaideri case, is just to do stent boost wherever you inflate the balloon.
Exactly.
See if there is a stent there or not. If there is a stent, you check. If you don't have image, well deployed, well not deployed. than if you just did a stent boost, and you will realize that there is no stent in this area.
Exactly.
Second,
Yes.
for Dr. Adnan, we know graft stent restenosis 50%. We're talking about 50% restenosis in the left main. You need really a strict follow-up in your guy. Probably he's going to end with surgery anyway. Restenosis عالي.
Yes.
Yes.
So
This is a type F. It is a perforation. You should close a perforation. This is an aorto-osteal lesion, and there is we should close the re-entry point. That's the main point. And at that time, the patient was died, and so we are using the graft stent, and the patient is still alive, and he is in a very good health. So not all the time there is a restenosis. Yes, Doctor.
قاعدة Dr. Adnan, the safety of the patient is paramount, whatever the stent type. Thank you, Dr. Adnan. Yeah, definitely. I'm totally agree with you. So okay, Doctor.
I would go with what Dr. Adnan did, because I
2
don't
minutes.
think it was a simple dissection. There was a tear in the left main, and that tear is multi pins, multi holes in it. So I would go with covered stent, no doubt. It wasn't a simple aorto-osteal dissection.
Anyhow, it's okay. The 1 minute left, right? So I'm going to talk with Dr. Ahmed. It's a very interesting case. I think the main predictor in stent dislodgement in Dr. Ahmed's case was inadequate lesion preparation. Very important, keep in our mind, meticulous lesion preparation prevent the stent dislodgement. Crushing deployment recently, it's a very attractive, very safe, and avoid unnecessary complication during retrieval. You can deploy the stent, you can crushing, depend on your wire, on and off, and keep in mind, should be never crush the stent in the proximal LID because there is a risk of stent thrombosis. And thank you very much for your attention.
Thank you very much. Thank you.
Last comment, just in such case, you are allowed to go outside the ostium to make sure you cover the ostial coverage. Thank you very much.
يلا الله يعطيكم العافية. عندنا آخر سيشن.